Welcome back, and we're going to continue from where you have left. It's a short topic only, so I don't know. I got some urgent issue to be sorted out, so that's why I just left a little bit. So now, and okay, let me see the chat. So whatever I told you, like this pathway, do you understand? Like at least an overview, because we don't want to dissect more. I think you can get what's happening over here. So this is a basic final take-home point. So whatever you need here, this will be fine. That's all. You don't need anything else to be known. Okay. So what are the effects of dopamine and what are the pathways that are there and what's going to be the effect of dopamine on movement? What are the effects of direct pathway on movement, indirect pathway on movement, subthalamic nucleus on movement, and what will be the problem due to nigrostrial degeneration? That's Parkinson's. What is the problem that's going to happen due to basal ganglia problem, hyperkinetic movement disorder? What is the problem due to substantia nigra issue? Subthalamic nucleus issue. That's again going to be a hyperkinetic movement disorder. And haloperidol can be used in hyperkinetic movement disorder as a treatment, but it can result in Parkinsonism if you use in psychotic patients as a side effect. And at the same time, L-DOPA can result in dyskinesia as hyperkinetic movement disorders, and it can be used as a treatment of Parkinsonism, but side effects is dyskinesia and psychosis, of course. Okay, we have this hyperkinetic and hypokinetic movement disorder, and many times they will ask you in exam, what is the treatment that you're going to use for hemipallismus? Of course, if they ask you the treatment for hemipallismus, you can go for tetrabenazine, and you can use haloperidol as well. There's no doubt. So, but in exam, usually the examiner expects the answer of tetrabenazine because tetrabenazine is a drug that reduces the dopamine synthesis in the presynaptic terminal. That's like a transport inhibitor. So they will prevent the dopamine synthesis in the presynaptic terminal. So which means they are also going to reduce the dopamine in the synaptic area. So the action of dopamine will be reduced because of tetrabenazine. So that's why they're used in hyperkinetic movement disorder. That is called hypokinetic movements, and hyperkinetic movements are there. You know what you mean by hypo and hyperkinetic. As far as hypokinetic is concerned, we have bradykinesia, or the patient may have complete akinesia, and they can have rigidity. Most of the features which I've told you, bradykinesia, akinesia, and rigidity, are basically due to loss of dopamine. That's the main reason. And hyperkinetic movement disorders. We have tics, one of the important hyperkinetic movement disorders. Then we have tremors. There are multiple different types of tremors, but right now tremors is one of the important hyperkinetic movement disorders. Then we have dystonias. So, that's like a kind of a contraction that you get in some part of the limb or in the neck. So dystonias, then you can have athetosis, and we have chorea, and we have hemipallismus. Only one hyperkinetic movement disorder that can be suppressed voluntarily. Suppressed by voluntary control. For example, you will have this kind of like tic syndromes that happen in childhood, where they'll have that poor foul. If you see that children, they can suppress the tics voluntarily if you ask them to do so for some time. But after some time, they can control voluntarily, but somehow it tends to match up, and after some time it tends to come with increased intensity. So, but still, that's the only hyperkinetic movement disorder, even though it comes with increased intensity later on, increased numbers later on, but it can be suppressed for time period with voluntary control. But apart from that, none of the other disorders can be basically suppressed with voluntary control. And if you go to chorea, then we have athetosis, and finally we have dystonias. These are a sort of like a little bit of jerky time kind of a movement. So as you move from left to right, as you move from myoclonus to balismus to chorea to athetosis to dystonia, the movements become relatively smooth, which means it will not be like violent and sudden jerky kind of movement. Rather, it will become more smooth and more consistent, rather than being violent and jerky. And that's what I'm telling. They'll become less violent, and they'll become less explosive, and at the same time they'll become less jerky, and at the same time they'll be more sustained. So less explosive, less jerky, less violent, but more sustained. That's what I'm trying to tell, and more flowing. For example, if you talk about a dystonia, there'll be something like this. There'll be the same thing like this for consistently. So it's a more sustained and a flowing kind of a movement rather than this kind of jerky kind of a movement that is not the setting that's so. Apart from that, we need to discuss a whole lot of Parkinsonism itself in the first place. As far as Parkinsonism is concerned, we have primary Parkinson, that is idiopathic Parkinson disease. That's, we can differentiate into primary, and you can have a lot of secondary Parkinsonism. So secondary, most common cause is basically the drugs, but you can have a lot of other reasons for developing a secondary Parkinsonism, but usually it's due to drugs. But as far as primary is concerned, there are many causes are there. It could be idiopathic Parkinson disease. It could be due to some vascular cause. It could be due to some demyelination, or it could be some trauma. Trauma is, like best example is Muhammad Ali, isn't it, who got a trauma and got Parkinson disease. And trauma can cause Parkinson disease, primary Parkinson disease. And of course, you have multiple other reasons as well, like tumors. Certain tumors near the basal ganglia region can result in the development of Parkinson disease features. Of course, among all this, the most common is going to be the idiopathic Parkinson disease. That's what is going to be very important. How we are going to differentiate between primary versus secondary Parkinson disease is the fact that in primary idiopathic Parkinson disease, the disease is going to be having prominent tremors, number one. That's the first thing. And second is the fact that they will be having asymmetric disease. Many students think that Parkinson disease is symmetric, but no, it's always asymmetric. That asymmetricity is a very important feature of idiopathic PD. If you don't have this asymmetricity, it's unlikely to be a primary or idiopathic Parkinson disease. It's not possible to have a Parkinson disease. Symmetric disease is not Parkinson's. I mean, in the sense like it's not an idiopathic PD. It's always asymmetric. It starts with one limb only. It progresses to either limbs. But even if it affects both the limbs, the limb that starts getting affected first will be the worst affected limb till their last breath, till their death. So that's a classic feature of idiopathic Parkinson disease, and you should never miss out this asymmetricity. As far as secondary causes are concerned, it will be more symmetric in nature, more symmetric, and usually they will not have that much of tremors. Though I can write that first. So tremors will not be a very important feature here. They'll not have tremors, and they'll be more symmetric in nature. So that separates this from the primary or idiopathic Parkinson disease. And what are the drugs that can result in this kind of secondary Parkinsonism? For example, metoclopramide can cause, has been discovered, but metoclopramide more often, rather than causing this kind of Parkinsonism, it will more cause of a dystonia, because dystonia is something like this kind of a movement, isn't it? That violent kind of a movement. So it will produce more of some kind of a dystonic kind of a movement, but rather than producing a Parkinson, you can get with haloperidol. I mean, antipsychotics in the sense like haloperidol and typical antipsychotics are the most important here, and other typical antipsychotics. Among the atypical antipsychotics, risperidone still poses a higher risk. Then you have sulpirides, which is very commonly used in modern practice as an antipsychotic drug. At the same time, it is used in a lot of proton pump inhibitors, because sulpirides has been approved in the treatment of. You can get this with another drug called MPTP. I mean, I'll not write here. I'll write separately. I don't know the expansion of MPTP really, but it's one of the drugs that's been used in 1930s for like cocaine, marijuana, recreational drug. But it was banned from the market because of its ability to produce Parkinsonism. But I don't think it is still banned from NEET PG exam. Still, it's been asked. So MPTP is one of the drugs that can cause Parkinsonism. That's a recreational drug that can result in the development of Parkinsonism. At the same time, there are another like variants of Parkinsonism are there, which we're not going to discuss. So these are called as Parkinson plus syndromes, which we'll be discussing subsequently. In the Parkinson plus syndrome, we have 3 disorders, that is multiple system atrophy, then we have progressive supranuclear palsy, then we have a corticobasal degeneration, CBD. 3 disorders are there in this Parkinson plus, which we'll be discussing subsequently nevertheless. And apart from that, we have another type of Parkinson called as post-encephalitic Parkinsonism. In 1910, this disease become very popular because after Spanish flu in the 1910s and 20s, many people have known to develop Parkinsonism. Especially those who are gone for encephalopathy. So that's why it's called as a post-encephalitic Parkinsonism. Still, it is still a risk. Some patients may develop. That's called a von Economo disease, but a very rare entity as of now. So that's called a post-encephalitic Parkinsonism. It's not only proven to happen after a viral infection; it can happen after any infectious encephalitis. You can get a Parkinsonism called as a post-encephalitis Parkinsonism, otherwise referred to as something called a von Economo disease. All right. So finally, like the most important of all is going to be the idiopathic Parkinson disease, and that's going to be the most common entity as well. So many things are reversible, but idiopathic Parkinson disease is completely irreversible, and you cannot reverse that at all. And it's a progressive neurodegenerative disease due to idiopathic degeneration of the nigrostrial neurons. So that's what I'm going to discuss now, idiopathic Parkinson disease. I'll do a small amount of discussion on Parkinson plus syndromes also. But idiopathic Parkinson disease becomes a very important thing here. And remember, as far as the genetics are concerned, there are certain genes that are having inherited with autosomal dominant kind of is inherited as an autosomal dominant fashion. And we have something called SRCA gene, which is also inherited as an autosomal dominant kind of fashion. And we have a PRKN gene, otherwise referred to as a Parkin gene, very famous. And we have a PINK1 gene. That's called a P10 induced kinase 1, PINK1 gene. And then we have a PARK7 gene. All these are implicated in the development of early onset Parkinsonism, but none of them as really tested in clinical practice, even though they have been implicated widely, but none of them have been commonly tested. So of course, of all these things, I will believe this Parkin and PARK7 are going to be important, because that could be probable questions. Apart from that, I don't think you will get any questions, because genetics in Parkinson is not really important, but genetics in Alzheimer is really important. Very commonly asked. And I think Alzheimer disease, I didn't tell you 2 points. In Alzheimer disease, one is smoking is protective. I forgot that. Smoking is supposed to be protective for few diseases like Alzheimer disease, and probably to an extent to ulcerative colitis, and to some extent to development of preeclampsia. It's been thought. So especially for Alzheimer disease and for ulcerative colitis, smoking is thought to be protective in nature. So which I forgot to tell yesterday. Then second thing that can increase the risk of developing Alzheimer's is illiteracy, low educational status. Second thing, because most of the Alzheimer's disease patients are poorly educated, like they're not across the 12th standard or college grade. So low education is a risk factor for developing Alzheimer. And third thing, I think which you have not told, is diabetes mellitus. Diabetes mellitus increases the risk of developing Alzheimer by 3 times compared to the general population without diabetes. So 3 things, if you want, you can add on to your notes. Diabetes, then smoking, then diabetes is risk, smoking is a protective factor, and illiteracy is a risk factor again. Low education. So clear. So this is, we have seen some of the genetics with regards to Parkinson disease. And as far as the pathophysiology is concerned, there's going to be nigrostrial degeneration, which means in the midbrain is where the problem is in Parkinson. Many people think it's the basal ganglia is where you're going to get the problem in Parkinson disease, but it's not the case. It's going to be the midbrain where you're going to have the problem, especially in the nigrostrial neuronal degeneration. And most of the times it will be idiopathic in nature. We don't know the cause. That will result in reduced dopamine. So this will result in something called pallor of substantia nigra. Pallor of substantia nigra. Normally, in a normal routine specimen, substantia nigra tends to be a little black because they are dopamine producing, and that's the name nigro, because they are black. Nigrostrial neurons, they'll be looking black basically in that area. That's why the name came. Niger means black. So the pallor, which means that blackness will be lost. So that's a pallor of substantia nigra, and that's a very classic gross specimen. In the gross specimens of Parkinson's disease patients, that's what we look for. If you see a substantia nigra that looks pale and it doesn't look black, then that indicates probably a patient is suffering from a Parkinson's disease. And this cannot be seen clinically, but one of the pathological appearances that you see. And apart from that, you have something called Lewy bodies, which can be seen in certain subsets of Parkinson's disease. Remember, Lewy bodies are seen only in probably 10 to 20% of the patients with Parkinsonism. And this presence of Lewy bodies, these are alpha-synuclein aggregates, and they are intracytoplasmic inclusion bodies, and they are eosinophilic in nature. I think we have discussed this yesterday in the NCD with Lewy bodies. They are intracytoplasmic in nature, and they are eosinophilic inclusion bodies. And 10 to 20% of the cases you might have Lewy bodies, and presence of Lewy bodies increase the risk of developing something called early onset dementia, number one. At the same time, they increase the risk of developing some other disorder called REM sleep behavioral disorder. There's something called REM sleep behavioral disorder, which I told you in dementia with Lewy bodies yesterday. So remember, first dementia or Parkinson, or first Parkinson or dementia is the question. So you develop first Parkinson, then after so many years you develop dementia, but still a little early in 3 to 5 years, then you can call that as a Parkinson related dementia. Suppose if you develop dementia, that neurocognitive disorder as a first entity, as a prominent entity with a lot of visual hallucination, or whether it's a movement disorder, that is the major issue. So movement disorder is the major issue, then you go for Parkinson disease and it's going there for a long time. After that, they will develop dementia. If the beginning itself, they have dementia as a primary problem and Parkinson is only an associated issue, then it will be putting under NCD with Lewy bodies. But nevertheless, presence of Lewy bodies increase the risk of developing REM sleep behavioral disorder. And apart from that, we have something called a Bragg staging. This is available for Alzheimer's disease also, but in Alzheimer's disease, it's not that validated, but in Parkinson, it is actually validated. That's called a Bragg staging in Parkinson. So you have 6 different stages. In the stage number 1, according to Bragg's research, is a scientist. So the dorsal motor nucleus of vagus is the one that is first affected. Dorsal motor nucleus of 10th cranial nerve, and the olfactory bulb is the first thing that is affected. And this could be one of the reasons why one of the important complaints, early complaints in Parkinson disease patients is anosmia. Currently, like even common public knows anosmia means COVID, fine. But according to Bragg's, one of the earliest findings in Parkinson disease is anosmia and reduced smell. That is because of involvement of the olfactory bulb in the first stage itself. Then second stage is where they're going to have problem in the gain setting nucleus. Gain setting nucleus. So one of the important gain setting nucleus in the brain is the nucleus basalis of Maynard. And this nucleus basalis of Maynard, you will be hearing in 2 areas. One, you will be hearing in the Alzheimer's disease, where they will tell that this because of the loss of acetylcholine, you will get dementia. And second, nucleus basalis of Maynard is involved in Parkinson's disease also, where they are supposed to produce more acetylcholine because of the loss of dopamine. And this excessive acetylcholine is the one that is thought to be drugs that are affecting dopaminergic pathway only is not going to affect the this kind of hyperkinetic disorder. The tremors will not happen. But if you take an idiopathic Parkinson's disease, because your Lewy bodies substantially start producing more and more acetylcholine from the nucleus basalis of Maynard, and it's going to affect the gain setting nucleus as well. So it will result in increased acetylcholine, and that's the reason for developing tremors in idiopathic Parkinson's disease. And the third area, this point only, they're going to affect the substantia nigra and the amygdala. So where you start to get that bradykinesia and rigidity because of the nigrostrial degeneration. And that is also one reason why tremors are one of the early findings in Parkinson's disease. Rather than this bradykinesia and rigidity, tremors will be the usual early finding. Then they start affecting the mesocortex and the thalamus. So once they start affecting the mesocortex and thalamus, these patients' thinking itself will be slowed down. So they cannot think properly. Their planning ability will be reduced. That's called a bradyphrenia. Like even speech will be slowed down. So the eye movements, even the number of eyelid closures, number of blinking they make is also reduced. So every single process will be affected. There will be not only bradykinesia, everything in the body will be slow. Even the thinking process, thought process will be slowed down. Then finally, they will start affecting the neocortex and the association areas. And last but not the least, they will start affecting the neocortex, the primary areas, where they go for the bedridden stage, complete motor deficit. So this is what is described by Bragg. It is well suited for Parkinson's disease, but it is not actually well suited for Alzheimer's disease to be precise. So Braak staging is available for both Parkinson and Alzheimer's disease, but for Parkinson disease, it's more classic and common. And I mean, he did years of research. I think he did around 18 years of research. And after that, he told the stages. So it has to be respected for sure, because such a huge experiment for 18 years. And I think this must be enough for exams like the Levy bodies, nigrostrial knee generation, pallor of substantia nigra. What are Levy bodies and what are its associations, and Braak staging, that's 6 stages. I think this must be enough. Then as far as the clinical features are concerned, classically, the clinical features of Parkinson include something called tremors. We can write by a mnemonic called TRAP. You know, there's a classic mnemonic for Parkinson. T stands for tremors, R stands for rigidity, and A stands for akinesia or bradykinesia. Akinesia or bradykinesia. And P stands for postural instability. Postural instability, of course, yes. So in that, tremors are supposed to be very early and very common finding of Parkinson disease. And we know what are the types of tremors we have. These are typically coarse kind of a tremors which happen at resting state. And typically it is going to be 4 to 12 hertz in frequency. Sorry, 4 to 6 hertz. 4 to 12 hertz is essential tremors. 4 to 6 hertz in frequency and typically pill rolling in nature. So when they give coarse resting 4 to 6 hertz pill rolling kind of a tremors, it's always a Parkinson kind of a tremor. But remember, if it's an idiopathic Parkinson disease, every single feature will be asymmetric. You cannot talk about symmetricity here. It's always asymmetric. One side will be always having more problems than the other side. Remember, head tremors will not happen in the setting of Parkinson. Whenever there is a head tremor, it goes more towards essential tremors in the exam. That's called titubation. So don't diagnose based on head tremors. And rigidity will be seen in more than 90, eventually, even though tremors is seen only in 70%, rigidity can be seen in a lot of people, more than 90% eventually develop rigidity. So typical type of rigidity will be cogwheel type of rigidity. So what do you mean by cogwheel type of rigidity? Whenever there is a rigidity that is interrupted by tremors. For example, if you do, it will be like this. So this kind of rigidity is what we refer to as kind of a cogwheel type of rigidity, which is basically characteristic of a Parkinson disease. And akinesia or bradykinesia is one of the classic features and is one of the most specific feature as far as Parkinson disease patient is concerned. Remember the word Parkinson, whatever may be the reason, the word Parkinson means this bradykinesia. Without bradykinesia, you cannot call that patient as to have Parkinson, even though clinically you can diagnose. But the word Parkinson basically means that the patient is having some form of bradykinesia. It's one of the very specific features of Parkinson disease. And because of bradykinesia, one other feature you will get is something called a gait freezing, which means suddenly they start walking and at one point, especially when there is a turn or when they want to move to some different direction, they freeze just like that because completely it is frozen, slowed down. So that's an extreme case of Parkinson. You get that kind of gait freezing, which again very specific for Parkinson, but happens in late stages. Postural instability. As a postural instability is concerned, it's a very, very early finding. Postural instability, late finding. Rigidity and akinesia are relatively specific findings for Parkinson. Tremors and postural instability are not specific. Rigidity and akinesia are relatively specific. Bradykinesia are supposed to be the most specific. And type of rigidity is cogwheel. Tremors are early. Coarse resting 4 to 6 hertz pill rolling type never happens in the head, and postural instability happens very late. That's a very important point because there are certain diseases which can cause early postural instability, like Scheidegger phenotype, which we'll be talking after some time, and you can have falls and fractures because of the postural instability. That's also a problem in old people who are getting Parkinson. And more importantly, if you take the motor activity, remember the power will be completely normal in Parkinson disease, despite the fact that they are slowed down, and the plantar response will be a flexor response. It will never be an extensor response. And usually the patient will not have any bladder and bowel involvement. And presence of early bladder and bowel involvement again goes to a different disease like Scheidegger syndrome, which we'll be discussing subsequently. And the patients will not have any sensory or cerebellar involvement. So no sensory, no cerebellar, which means it's a movement disorder. So why it should affect the sensations? Sensory involvement. Clear? This is very important. So no loss of power, no plantar extensor, no bladder and bowel involvement, and no sensory and no cerebellar involvement. I should have written cerebellar. No cerebellar involvement. So these are very important to diagnose Parkinson, and in exam you should be very crystal clear in telling all these things. And there are many other problems that these patients can encounter. Like for example, they can have psychiatric issues, and very commonly they go for depression, anxiety, and all this stuff. As I told you, there's a subcortical problem. Subcortical problems are, going to have more depression and anxiety compared to the cortical problems. Yesterday we discussed in the NCDs itself. They're going to produce more depression and anxiety. And cognitive dysfunction may happen in the form of a subcortical dementia, or currently we can call it as a subcortical neurocognitive disorder or a subcortical dementia. And the sleep disorders are very, very common. Remember, a lot of patients will be having the typical REM sleep behavioral disorder. And REM sleep behavioral nervous system problems can develop later on. And in that, constipation is a problem, not incontinence. Constipation is one of the very common problems in Alzheimer's disease as well as Parkinson's disease or any neurodegenerative disorder. At the same time, they can have orthostatic hypotension, but these are very late. Orthostatic hypotension. And they can have anosmia, that is because of olfactory bulb involvement, I told you. They can have micrographia, very commonly asked question in exam. They have a small handwriting. Remember, micrographia is a is a feature of Parkinson's disease, and macrographia is a feature of cerebellar disorders. So micro for Parkinson, macrographia for cerebellar disorders. And they can have fatigue, weight loss because of poor eating and poor concentration. So many different features are there, but I think this must be enough. So in that, what are asked in exams already is depression has been asked, subcortical, take it for granted. Everything has been asked. And especially the most important will be this only. So that you should know that the power is still normal. Plantar should be still flexor, no bladder and bowel involvement, no sensory and no cerebellar involvement as far as Parkinson's disease is concerned. I have to tell 2 more times also to make you understand that it is important. And the diagnosis is clinical only. So I'm going to do a clinical diagnosis, of course. But if you want to do a scan, you can do something called a DAT scan that is available. The dopamine uptake scan, that's a dopamine transporter scan. We are going to use something called a ioflupine in this. And remember, the DAT scan is currently done not to diagnose Parkinson's disease. Even though it can show some findings that are, characteristic of Parkinson's disease, but more than that, it is to differentiate essential tremors versus Parkinson's disease, especially if you are having an early disease. In the early stages, Parkinson may not have rigidity and bradykinesia typically. They might have only tremors. So in that setting, there is another differential diagnosis, essential tremors. So let us see how clinically we can differentiate essential tremors, family history in the setting of Parkinson is. Apart from rarer genetic causes, which I have discussed, apart from that, they don't really have any much family history. And of course, essential tremors is going to be symmetric in nature. The tremors will be symmetric, and one of the classic features of Parkinson's disease is its asymmetricity. They're going to have asymmetric tremors only. And essential tremors is characterized by the presence of head tremors, that's otherwise referred to as titubation. But as I told you multiple times, Parkinson's disease patients will never have this kind of head tremors. They might have jaw tremors, even tongue tremors have been described, but head tremors, this kind of nodding movements have not been described. And postural variation of tremors. Postural variation of tremors is one of the important features of essential tremors, but it's not a feature of Parkinson tremor. In the sense, like essential tremor patients will get tremors mostly with the outstretched hands, like this. So that is why it's very difficult for them to, it can be disabled something with upright posture and outstretched hands, the tremors will become violent. So that will result in a serious disability also. So that has to be taken care. So postural variation of the tremors. Then alcohol effect on tremors will reduce the tremors, and you don't have any such effect like that. Suppose if you have bradykinesia, that becomes absolutely specific for Parkinson's disease, but it will not be there in the setting of essential tremors. And of course, treatment, even though alcohol reduces tremors, treatment is not 2 pecks of whiskey daily. You have to treat with beta blockade. Here, treatment, of course, is going to be levodopa and anticholinergic drugs. If the tremor is the main problem, then anticholinergic drugs have to be added. Because tremors in Parkinson, if they ask you, it's due to more acetylcholine, not due to loss of dopamine. more acetylcholine is the main reason for getting tremors, just not because of loss of dopamine. That's due to some ACH-induced reverberating circuits within the basal ganglia causing the tremors. Okay. What are the differential diagnoses of Parkinson's disease? So you have multiple differential diagnoses like strokes, toxins, and one more important thing which you have not discussed about Parkinson is manganese. That's been asked sometimes. So manganese can result in development of Parkinson's disease as well. Manganese toxicity. Further matters any as per the research, the only one thing that has good evidence to say that it has association with Parkinson is manganese toxicity. Clear? Atypical Parkinson in the sense it will come under Parkinson plus syndromes. As I told you, there are 3 atypical Parkinson features. One is your MSA, that is multiple system atrophy. Second is PSP, that is progressive supranuclear palsy. And third is the CBD, that is corticobasal degeneration. All these are atypical Parkinsonism. CBD will be asymmetric only, but except CBD, most of the case of atypical Parkinson or Parkinson plus syndromes will be symmetric in nature, and they'll be happening in age more than 60, which means they will happen usually in elderly patients, but Parkinson can happen in younger as well as elder patients. Even 40-45 years you can get prognosis. Why it's going to have a poor prognosis? Because of many reasons, and one of the important reasons is they're going to have reduced response to levodopa. Reduced response to levodopa. Most of the patients will die within 5 to 7 years. Most of them. All these are actually contradictory to Parkinson's disease is supposed to have a decently better prognosis in the sense like it's a neurodegenerative disorder. It cannot be stopped, but the response to treatment will be extremely good. Levodopa is considered to be the gold standard for Parkinson's disease treatment. So the response levodopa will be excellent in setting of Parkinson's disease. Here there will be a poor response. And one important feature of Parkinson's disease is slow progression. It will take at least 10 to 25 years for Parkinson's disease to get severe disability and die. But in the setting of Parkinson plus, they die within 5 to 7 years, which means a relatively faster progression. Whereas Parkinson is marked by extremely slow progression. Like 10 to 25 years is the usual time where the Parkinson becomes extremely severe and makes the patient bedridden, which means I can tell a decent prognosis with Parkinson's disease. If you're diagnosed with idiopathic Parkinson's disease, it can disable you, but usually it doesn't kill you. That's the idea. So next, coming to the 3 disorders that we're talking about, MSA, PSP, and CBD. As far as multiple system atrophy is concerned, we have 3 different types. One is called the MSA-P. This is called MSA of Parkinson type. So here the patient will have bradykinesia and rigidity, but they will not have any tremors. They will not have any tremors. And that rigidity will be more of an axial more than appendicular rigidity. That's very important. And the key feature that differentiates from Parkinson is the tremors that these patients are having. Tremors that these patients are not having conspicuously, wherein Parkinson tremors are extremely common. And the prominent finding in these patients will be the rigidity rather than the bradykinesia. And they'll have severe axial rigidity compared to that of appendicular rigidity. So sometimes this severe axial rigidity can make the patient go for some abnormal postures like this and all. That's called as a Pisa sign. That is leaning tower of Pisa. So that's because of the severe axial rigidity they get, and they go for some abnormal postures like leaning posture and all. That's what we refer to as something called a Pisa sign. Multiple system atrophy. And apart from that, you have MSA of cerebellar type. Here the patient can have bradykinesia and rigidity. Along with that, the patient will have something called as cerebellar features. They can have tremors as well, but they predominantly tend to have cerebellar kind of tremors. Cerebellar features. Like ataxia, nystagmus, a cerebellar kind of tremor. Cerebellar kind of tremor will also be coarse, but the frequency will be less. As I told you before, this tremors is more of coarse resting 4 to 6 hertz. Remember, cerebellar also will be coarse, but will not be resting. It's more of an intentional tremors, which means only during movement you will get tremors, and it's more of a low frequency, 2 to 4 hertz tremors. And this is for cerebellum. These are cerebellar tremors. Okay, so they'll more of cerebellar feature. That's why it's called a MSA-C. But one important finding of MSA-C in MRI is something called as hot cross bun appearance. That's been regularly described in any radiology textbook, as any radiology class, you will encounter this hot cross bun appearance in the midbrain, which I'll show you maybe in the next session, maybe in the 15 minutes, I'll show you what is hot cross bun syndrome, where the patient will have bradycardia and rigidity, but the patient will have predominant autonomic nervous system features. ANS features will be there. Like they have postural instability or the setting of postural hypotension, and they will have bladder and bowel involvement. So we know that bladder and bowel involvement is not a typical feature of Parkinson disease. So this bladder and bowel involvement is not a very typical feature of Parkinson. That's why we have described here no bladder and bowel involvement and no cerebellar involvement. If there is a prominent cerebellar involvement, then I will think about MSAC. If it's a prominent bladder and bowel involvement, I'll be thinking about probably a Scheidegger phenotype. So nevertheless, so these are the features that go towards a multiple system atrophy, MSA, rather than a idiopathic Parkinson disease. And as far as progressive supranuclear palsy is concerned, like here again, you're going to get a bradycardia and rigidity, but it will be more symmetric in nature, and it's typical in age more than 60, as I told you. And tremors will be conspicuously absent; they will not have any tremors in the first place. And most of these patients will have this gaze palsy. That's a supranuclear type of gaze palsy. Whenever it is supranuclear gaze palsy, it always means vertical gaze palsy. And this vertical gaze palsy will be more for down gaze than up gaze. That really tells you the difference from Parinaud syndrome. In Parinaud syndrome, we'll have up gaze more than down gaze, whereas in PSP, you'll have more of a down gaze involvement rather than up gaze involvement. But most important thing that differentiates this PSP from your idiopathic Parkinson disease is the early postural instability. Early postural instability. And this will present as falls and fractures. Usually this will be at presentation. At presentation, they'll be presenting with falls and fractures. And that differentiates from idiopathic Parkinson disease, because we have described already that this postural instability is supposed to be very late in the setting of Parkinson disease, but that happens very early in the setting of progressive supranuclear palsy. Whenever the examiner gives you falls at the time of presentation itself, you go towards the PSP as a diagnosis. That's very important. And if coupled to that, if they have a predominant down and up gaze palsy, then you can go for a PSP diagnosis. And apart from that, they can have multiple other problems like surprised look. That is because of the contraction paralysis of oculomotor supercilii muscle, which will always lift their eyebrows like this. So they'll have kind of a surprised look most of the time. And they will have something called square wave jerks also. Remember, this has a high sensitivity, but a poor specificity, which means almost all the patients with PSP will have square wave jerks. But unfortunately, presence of square wave jerks in the eyes is not specific for PSP diagnosis. It can be seen in many other conditions as well. And there are two MRI findings that they will ask you. One is in the sagittal section. You will typically see a sign called hummingbird sign, or otherwise referred to as penguin sign or hummingbird sign. And in the axial sections, you will be seeing something called Mickey Mouse ears. Mickey Mouse ears. So both the signs have been asked multiple times in exam, which I'll try to show you in the afternoon session for half an hour. So hummingbird sign and Mickey Mouse ears, very important MRI findings as far as the PSP is concerned. Multiple times asked question. As far as corticobasal degeneration is concerned, the most important feature of corticobasal degeneration is the fact that it is asymmetric, and it's going to usually affect upper limb more than lower limbs. And more importantly, this upper limb that is very commonly affected in the setting of CBD is going to be on the non-dominant side. Very classic. Non-dominant upper limb will be affected, which means only one limb will be affected. So non-dominant upper limb will be the one that will be affected in the setting of a corticobasal degeneration. In that upper limb, what are the findings you will be seeing? Or in the affected limb, what will be the finding you will be seeing? You will be seeing bradykinesia, rigidity, which means these are Parkinson features. And tremors will not be there typically, but they will go for dystonias, abnormal postures, dystonias. And they can get myoclonus in that limb, sudden jerky movements, despite having bradykinesia and rigidity. And they will have apraxias. One of the important apraxias that these patients get is something called an alien hand phenomenon. And this is quite interesting. What do you mean by alien hand phenomenon? One hand interfering with the movement of the other hand involuntarily. Like this is not a voluntary phenomenon. So for example, if I'm writing something, this other hand might involve involuntarily, like it can prevent my writing. So as if some alien is there in my limb and doing something nonsense. So this is what we refer to as an alien hand phenomenon. That's a kind of an apraxia that you get in patients. So in exam, even though alien hand phenomenon can happen in the setting of a frontotemporal neurocognitive disorder, FTD, but alien hand phenomenon in exam usually goes towards a corticobasal degeneration. That's not very specific for CBD, but still in exam, these are the stereotypical points that they give. So Parkinson-like features, asymmetric, getting an alien hand phenomenon, goes towards a CBD in exam. So this is also one of the examples of tauopathy. So important fact is to know that this is an example of a tauopathy. But so now it's time to know what are the tauopathies. I think I forgot to tell yesterday. What are the tauopathies? The first tauopathy is always Alzheimer's disease in the form of neurofibrillary tangles. Then we have the frontotemporal dementia, where you call them as pig bodies or pig's disease. Then you have PSP is also an example of tauopathy, that is progressive supranuclear palsy. Then CBD is also an example of tauopathy. Then there is another entity called chronic traumatic. So I can write PSP is also a type of tauopathy only. So PSP, CBD, and apart from that, we know that, where is that? PSP, CBD, apart from that, we know that Alzheimer's disease, even PIC's disease, that is frontotemporal neurocognitive disorder, especially behavioral variant, and chronic traumatic encephalopathy, all these things are basically tauopathies, where you can see accumulation of tau proteins within the cell. Now, finishing off, you need to know the treatment. Remember, the treatment for atypical Parkinsonism is very difficult, and they will have a poor response to levodopa. They will not respond like Parkinson disease. So now we are going for idiopathic PD treatment. How do you treat an idiopathic Parkinson disease? Idiopathic PD, first look for the age of the patient. As far as age is concerned, whether it can be less than 60 or more than 60. From neurological standpoint, less than 60 means young, more than 60 means old. More than 60 is straightforward. I am going to start with levodopa only. Levodopa is one of the best drugs that you can give for Parkinson. I feel it's the gold standard. The best response in Parkinson is you will be getting with levodopa. It's been there for 50 years, but still there is no drug that can equate levodopa in the response as far as Parkinson disease is concerned. Of course, we are going to use with or without carbidopa. You know why carbidopa is used? Carbidopa is a peripheral dopa decouplase inhibitor, which means it prevents the conversion of L-dopa to dopamine in the periphery. So carbidopa can increase the CNS concentration of levodopa. CNS concentration of dopamine, more than that. CNS concentration of dopamine, and you can write levodopa also, because levodopa in the brain is going to get converted to dopamine only anyways. So to increase the CNS concentration of levodopa and dopamine, carbidopa may be useful, because carbidopa acts like a peripheral dopa decarboxylase inhibitor. So remember, if all the levodopa by peripheral dopa decarboxylase, if it's converted to dopamine, you'll get dopaminergic side effects, and it's not useful. So to inhibit the peripheral dopa decarboxylase, you will give carbidopa. So now you can increase the movement of levodopa as such into the brain without getting converted dopamine in the periphery. So the concentration of levodopa in the brain increases. So the availability of dopamine in the brain will increase. So carbidopa is a good drug to add. It's commonly available in the brand name called Syndopa, where you have carbidopa and levodopa together. As far as older patients are concerned, younger patients are concerned, you see what is the prominent disease type. So whether it's a tremor predominant or whether it's a bradykinesia predominant. So what is the predominant type of the disease? What is typically concerning the patient? Suppose if it's tremor predominant, we know that is due to excessive acetylcholine. So in this setting, I'll be giving anticholinergic drugs, and these are central anticholinergic drugs. Like for example, I can give a trihexyphenidyl, THP, Benadryl. So many drugs are there. So trihexyphenidyl is a classic drug that we use, that's available in the brand name called Pacitin. And at the same time, suppose if you have a bradykinesia predominant or a bradykinesia and rigidity predominant disease, which means we know that dopamine is the problem here. So in this setting, it's better to use dopamine receptor agonists in this setting. So there are two types of dopamine receptor agonists. One is non-ergot type of dopamine receptor agonists, and ergot type of compounds are there. Ergot type of compounds are bromocriptine, cabergoline, and pergolide. But we generally avoid these drugs basically in Parkinson. So this is limited to use in your pituitary adenomas, especially lactotroph adenomas where high prolactin is there. In that setting, these drugs are used because in that situation, it is used in a very lower dose. At the same time, they will be given for a short period of time only. Why? Because these drugs have a higher risk of producing valvular heart disease. So an echo monitoring is mandatory with these drugs. And Parkinson disease, because they need higher doses and consistently for a longer period of time, it's better that you avoid this ergot group of compounds. And non-ergot group of compounds, on the other hand, you can use as ropinirole. This is preferred for Parkinson disease. Remember, these drugs are preferred in lactotroph adenoma or hyperprolactinemia. So there this preferred, not for Parkinson. As far as non-ergot compounds are concerned, you have ropinirole and pramipexole. Ropinirole is a very commonly used drug. And these are the drugs that are preferred in Parkinson disease treatment. Parkinson disease treatment. And there are multiple side effects with regards to dopamine receptor agonists, especially the non-ergot compounds. I mean, ergot compounds have even more side effects. That's different. So what are the side effects of commonly used non-ergot compounds in Parkinson? Remember, first of all, they are less efficacious. The efficacy compared to levodopa is much lesser. Levodopa is the gold standard, as I told you. It's going to have less efficacy. At the same time, they can produce heavy sedation compared to levodopa, and they can produce a lot of peripheral edema. And the psychosis risk is much higher compared to that of levodopa, even higher than levodopa, psychosis risk. And one of the important psychiatric problems I told is obsessive compulsive disorder, especially in the form of compulsive gambling, multiple times asked question in exam. And they can produce serious dyskinesias like levodopa. This is a common side effect. Dyskinesia can happen with levodopa as well as dopamine receptor agonists. And what are the side effects of L-dopa? L-dopa side effects, typically dopaminergic side effects in the periphery, like tachycardia, action of dopamine on the heart, and they can produce orthostatic hypotension, ANS instability, again a peripheral dopaminergic effect. They can result in development of nausea and vomiting, again a peripheral dopaminergic effect. And they can have central effects. What are the central effects of levodopa? Dyskinesias. Because increased dopamine suddenly in the brain will result in development of dyskinesias, and you can develop psychosis also. But the incidence is less compared to that of dopamine receptor agonists, but still they can develop psychosis. These are the peripheral side effects of levodopa, and these two are the central side effects of levodopa: dyskinesias and psychosis. And a patient who's been suspected to have Parkinson disease, and after starting with levodopa, in the second day they developed severe dyskinesias. It's a good prognostic sign or a bad prognostic sign. Second day of giving, the same day or next day of giving levodopa, the patient comes back saying that he's getting serious dyskinesias. It's a good prognostic sign or a bad prognostic sign. I think I've told you multiple times, maybe in some other classes, it's a good prognostic sign, basically, because it indicates a levodopa responsiveness. So that's good, actually. That tells you, when you get a dyskinesia because of levodopa, it indicates that the problem is dopamine loss. Why? Because when you take the circuitry over here, when you take the circuit that I have been describing, so the Parkinson disease is due to the loss of nigrostrial neurons, isn't it? When you don't have this nigrostrial neurons, the neostriatum is basically, the basal ganglia neostriatum is basically starved of dopamine. So if they do not have dopamine for a long time, they're going to upregulate the receptors. This is called degeneration supersensitivity. We know that. They're going to upregulate the dopamine receptors, and suddenly you give dopamine in the form of levodopa. It will stimulate the basal ganglia very nicely, and that's one reason why you get this serious dyskinesia. So that kind of, dyskinesias that happening, in an increased amount after starting levodopa tells you that the problem is dopamine loss, and that dopamine loss is due to nigrostrial degeneration, and it tells you that the disease is actually a Parkinson disease only. For sure, it confirms it's a Parkinson disease, because if it's going to be an atypical Parkinsonism, you are really going to end up in a bad prognosis, not a very good prognosis. So if you get a good dyskinesia, it tells you that dopamine deficiency is the problem, and that indicates a good L-DOPA responsiveness, which means the disease must be Parkinson, which is going to have a slower progression, and it has a decent prognosis compared to that of other forms of atypical Parkinsonism. Nevertheless, you have other drugs that you can use to treat Parkinson disease. There are many other drugs out there. For example, you have MAV inhibitors, because monoamine oxidase are amine degraders. One of the important amine is dopamine. They can and monoamine oxidase inhibits noradrenaline amine, adrenaline amine, dopamine amine. So all these amines are basically degraded by one of the important enzyme called MAV. So you can reduce the degradation of dopamine so that you can increase the dopaminergic effect in the brain. So MAV inhibitors like seligilin, rasagiline, and your pharmacology textbooks will give a lot of MAV inhibitors like MAV-A inhibitors, MAV-B inhibitors, non-selective MAV inhibitors. I don't want that. Right now, we're talking about a MAV inhibitor here, seligilin and rasagiline, very commonly used drug in Parkinson, to reduce the degradation of dopamine, and so that they can increase the concentration of dopamine in the brain. Then you have COMT inhibitors, that is catechol O-methyl transferase inhibitors. And this is another way where they can inhibit degrade the amines. That is catechol O-methyl transferase. It's present both in periphery as well as in the brain. So two drugs that can inhibit is entacapone and tolcapone. Entacapone and tolcapone. Remember, tolcapone is the one that enters the blood-brain barrier. Entacapone usually does not enter the blood-brain barrier. The ticket to blood-brain barrier is with tolcapone only. You can remember toll as the toll to enter the blood-brain barrier. And but the problem with this tolcapone is it can cause serious hepatotoxicity, and you have to monitor LFT. Not a very commonly used drug, costly, toxic as well. They can have serious hepatotoxicity, and LFTs have to be monitored with tolcapone. You can remember, like, tolcapone is the one that has L in it, so that's the one that's going to produce liver toxicity. So LFTs have to be monitored. Tolcapone as the toll to cross blood-brain barrier, and L stands for LFT, should be monitored. And number 3, you have amantadine. Moderate response will be there, not a very good response. You can use in young onset Parkinson disease, and at the same time for L-DOPA induced dyskinesias, this drug may be helpful. And who are having L-DOPA induced dyskinesias and that impacts the quality of life, you can prefer amantadine in this patients. For old patients, typically we don't use because it has only a moderate response or a mild to moderate response, not a very good drug like levodopa. But still, you can use in young onset Parkinson disease with a severe levodopa-induced dyskinesias that affect the quality of life, which means levodopa cannot be used. Means in those patients, you can use amantadine as a bridge. But many students do ask me, if L-DOPA is the gold standard, then why can't you use in younger patients? Why want to use only in older patients? The reason is older patients, dyskinesias will not be a serious issue, but in younger patients, dyskinesia is very problematic. For example, when you sit in a theater, I mean, it's a funny sight, but still, when you sit in a theater, and when you get a leg dyskinesia and you are going under the seat and you are, like stimulating the next lady's leg, then that will be a problem. So apart from the funny side, this is quite a complication in younger patients. So we don't want that serious dyskinesias to happen. That's why we don't give levodopa, number 1. Second thing, by far levodopa, we know it's one of the best drugs in Parkinson disease. So these are neurodegenerative diseases which don't have any definitive treatment. So that's why we wanted to preserve the best for the last. Like you preserve levodopa, you have a definite response to levodopa for sure at any time you start in Parkinson disease. So you conserve that drug. So later on, especially for younger patients, because if the disease starts young, anyway, it's not going to stop. It's a neurodegenerative disorder. It's going to continue for lifelong. So you preserve that drug for the later stages. So that's the second reason why you don't give levodopa as soon as the diagnosis is established in younger patients. Then you have a drug called apomorphine, which increases the dopaminergic activity in the synapse. Very good drug, basically. Subcutaneous drug. It can reduce the off nature of Parkinson substantially. So that's why in textbooks they would have given it's one of the best drug for treating on-off phenomenon, especially during the off stages of Parkinson disease. You can use apomorphine as a very important drug. You might be wondering, what do you mean by on-off phenomenon? Suddenly I told you something called on-off phenomenon. It all depends on the levodopa kinetics. Levodopa kinetics tend to change substantially over a period of time. Yeah, the main arrow is preferred for the final battle. Mahavarda link. Okay. So levodopa is something that is, like going to have a substantial difference in the pharmacokinetics as it moves from like early period to the later period. In the early period, they will have a little bit of sustained response, and the therapeutic, dose of treating levodopa is going to be a little, like when, for example, if you take in early period, this will be the response. For example, to draw in a curve, it's easier. So first, let us assume this is the response threshold for levodopa, and let us assume this is the side effect threshold, or side effect threshold since I'm talking about dyskinesias. That's the most important, side effect threshold. And you have a gap where you have some kind of therapeutic response which is optimal. So this gap is what we refer to as an optimal response. So we need to maintain the levodopa in the optimal level. So, and you have some gap will be there. As you move further, the kinetics will become a little different from what we have seen, where the response threshold will be a little high and the side effect threshold will be a little low. So this will be the side effect threshold and this will be the response threshold. So the way we can work up is going to be very, very less. Our cushion is very less now. So what will happen is, if I increase the dose of levodopa, suppose if I'm trying to increase the dose of levodopa, they will end up with dyskinesias. If I reduce the dose of levodopa, then I'll have an off response, which means the patient will be frozen. In the sense, like patient will have severe bradykinesia and they will be frozen at one place. So this kind of change in the pharmacokinetics is a problem. So to reduce the response threshold, at the same time, to reduce the off value. So which means you can give a drug called apomorphine. So this apomorphine increases the sensitivity of dopamine at the synaptic terminal. So which means that you can reduce the response to levodopa. At the same time, apomorphine is something that increases this response threshold. At the same time, not increases, it makes the response threshold better. And at the same time, they can reduce the off state of the Parkinson's disease patients. That happens in every Parkinson's disease patient over a period of time. So that is why typically to reduce the off status in Parkinson's disease patients, and if you have more side effects when you increase the levodopa, you can prefer using apomorphine to bridge that. It's a very good drug. It's used as subcutaneous injection. That's the only problem. But apart from that, it's a very good drug, apomorphine. So that this is what we refer to as something called the on-off phenomenon. On-off phenomenon is common even in early stages of Parkinson, but the number of on periods and off periods will be variable as the levodopa is given for a longer period of time. The off periods will be more as the, as you progress towards the later stages of Parkinson's disease. And to avoid that, you can use apomorphine. That's the straightforward answer. And at the same time, if you try to increase the dose of levodopa in later stages, because like the side effect, this thing is also, dyskinesia threshold is also a little less, suddenly you will start getting more dyskinesia. So you will be in a situation where if you reduce the drug, you will go for off phenomenon more. If you increase the drug, they'll go for dyskinesia. So to keep the patient on, at the same time, they should not develop dyskinesias, you can bridge it with apomorphine. That's the idea. Okay. Then if still there is no response, we have some surgeries are there. For example, we have DBS, that's called a deep brain stimulation. So as far as the DBS is concerned, deep brain stimulation is concerned, you can do in 3 areas basically. One is the subthalamic nucleus DBS is there, where you can stimulate. And DBS always should be done bilaterally, should not be done unilaterally, which can worsen the disease. Or you can do in thalamus, called as thalamic DBS. And third one, you have the globus pallidus internus DBS, always referred to as a GPH DBS. As far as the Parkinson's disease is concerned, this is considered to be the best option, that is subthalamic nucleus DBS, because they can reduce all the symptoms of Parkinson's disease according to the research. And as far as thalamic DBS is concerned, they can reduce tremors substantially. So which means thalamic DBS is more preferable for patients with refractory essential tremors, or in exam specifically, if they ask Parkinson's disease patients with refractory tremors, in those people, maybe you can prefer thalamic DBS. But all the other patients with Parkinson, apart from those who are having refractory tremors, subthalamic nucleus DBS will be the best option. But thalamic DBS is best for refractory essential tremors. And GPH DBS, globus pallidus internus DBS, GPH DBS, to be honest. So which means what it will allow is, because the amount of dyskinesias that you get with levodopa is less, this will allow you to increase the dose of levodopa without getting side effects. You can increase the dose of levodopa without getting side effects. So that's what you're going to do. And 11, treatment of L-DOPA into psychosis. Surely you have to use atypical antipsychotics only. You should not use typical antipsychotics which can worsen the Parkinsonism. You're going to use atypical antipsychotics, probably like clozapine or olanzapine might be beneficial in that scenario. So even quetiapine might be beneficial, but typically, I mean, you should not use any typical antipsychotics there. You have to use only atypical antipsychotics, which does not work on the dopaminergic pathway. So anyway, so increased L-DOPA, I mean, you can increase the dose of L-DOPA without dyskinesia. But subthalamic nucleus DBS, since it touches the Parkinson disease itself, you can basically use this to reduce the dose of L-DOPA. It will allow you to reduce the dose of L-DOPA, which means subthalamic nucleus DBS itself will treat the Parkinson disease, and the dose of levodopa you need will be less. So it will allow you to reduce the dose of levodopa, whereas GPA DBS is going to decrease the L-DOPA into dyskinesia, so that you are going to increase the dose of L-DOPA without dyskinesia. So both have benefits, but of course, if you want to prefer one, I'll prefer only subthalamic nucleus DBS for Parkinson disease. There are other, indications for DBS in Parkinson. So for example, what are the indications for DBS if you want to know? The first indication for DBS is idiopathic PD. We know that that's what we've been seeing for long. And second indication is, if the patient is having excellent L-DOPA response, which means without a good L-DOPA response, you cannot really give a DBS. And the patient is predominantly suffering from off symptoms most of the times. And fourth, a patient is having a lot of motor fluctuations, severe dyskinesias and motor fluctuations. And a lot of motor fluctuations are there, which means on-off phenomenon feature are more, and more dyskinesias is also there. Or if the patient is having uncontrolled tremors, or plus that the patient should not have any psychiatric or cognitive dysfunction. No psychiatric or cognitive dysfunction. These are the rules or indications to do a DBS in Parkinson. Patient should be suffering only from idiopathic Parkinson disease, a good L-DOPA response, predominant off symptoms, lot of dyskinesias if you increase the dose of L-DOPA, uncontrolled tremors. At the same time, they should not have any psychiatric and cognitive dysfunction. So these are the typical indications for like using a DBS, deep brain stimulation. Apart from that, you might be asking about what are the other areas, where you can use DBS. Apart from idiopathic PD, what are the other places where you can use DBS? One is Tourette syndrome. That's called Killes-Dila-Tourette syndrome. It's a tic disorder, which can be suppressed voluntarily. But anyway, after that, it will come at an increased intensity. The initial treatment for Tourette syndrome is haloperidol again, because it's a hyperkinetic movement disorder. But nevertheless, you can use globus pallidus internus DBS in this setting to suppress these tics. And you can use in obsessive compulsive disorder also, where I can use the DBS in anterointernal capsule, and we can use GBS in patients with refractory depression, where you can put a deep brain stimulation rod in the cingulate gyrus or cingulate cortex. And alcohol dependence, chronic alcoholism, refractory, you can use DBS, whereas some evidence to use the DBS electrodes in the nucleus accumbens. NA stands for nucleus accumbens. And for refractory cluster headache, you can use DBS in hypothalamus, hypothalamic DBS. These are the other areas where you can use DBS, but of course, the unequivocal example of using a DBS is idiopathic Parkinson disease. That is the unequivocal area. Remember, apart from idiopathic Parkinson disease, you cannot use DBS in atypical Parkinson. It has not been approved yet, and the studies have showed that it's not going to cause any kind of improvement by using DBS in atypical Parkinson. So only for idiopathic PD right now, DBS is approved. And finally, I'll finish off with the cause of tremors. So what are the cause of tremors? You have physiological tremors, so which can happen in the setting of stress, anxiety, or when you're using too much of caffeine, coffee can cause tremors, or it can be medication-induced tremors. A lot of drugs can induce tremors, like valproate can induce tremors, tricyclic antidepressants can induce tremors, and amiodarone can induce tremors, and calcium inhibitors, especially cyclosporin, can induce tremors. We know cyclosporin, tacrolimus, in that cyclosporin is more prone for causing this tremors, hirsutism, and all this stuff. And alcohol withdrawal, rather than alcohol treatment, alcohol withdrawal can result in development of tremors, and steroids also can induce sort of tremors. So then we have this clinical disorders that can result in development of tremors. So we can talk about a metabolic disorder that causes tremors, like you can get with pheochromocytoma, that's due to catecholaminergic excess. Yes, beta-2 agonists, of course. Beta-2 agonists can also cause tremors, especially if you use IV. Surely they can cause tremors. Or subcutaneous, you can cause tremors in a higher intensity. Or chronic bronchial asthmatic COPD patients who are using long-standing beta-2 agonists can result in tremors. Pheochromocytoma can cause. Hypoglycemia can cause tremors. And hyperthyroidism can cause tremors. So some examples of where you can get a tremor. Apart from we have discussed already about the Parkinson disease, cerebral disease, essential tremors. Apart from that, other cause of tremors, you can remember this, because this is very useful for final year exams. That's why. So whenever they ask about tremors, you can tell this kind of causes that causes tremors, clinical disorder that causes tremors. And usually, like whenever you attend a clinical exam, they expect this only. That's very easy to answer, not a big deal. And you have cause of chorea also. What do you mean by chorea? Chorea is basically a semi-purposeful or quasi-purposeful movement. It's not a very fully purposeful movement. For example, I can get a sudden jerky movement, but I'll do like this. Okay, I make it as a purpose. I'll get a sudden movement again, so I'll take a pen like this. So it's not fully non-purposeful, or it is not fully purposeful. The patient knows that they're getting this kind of movement, so that to make it better, they make it look like purposeful. So this is what we called as a semi-purposeful or a quasi-purposeful movement. So first point about chorea is it is semi-purposeful, number one, and it's uncontrollable, which means you cannot control this movement. Voluntary like tics, it cannot be controlled. It will come anyway. Etiology wise, acute rheumatic fever, especially that is typically called as something called as Sydenham's chorea. We know that, otherwise referred to as Saint Vitus dance. Yes, we know that. So this is something very easy to understand. At the same time, pregnancy can cause chorea sometimes. That is called a chorea gravidarum. It can be due to rheumatic fever, or it may not be due to rheumatic fever, but pregnancy can cause called as chorea gravidarum. And we have stroke can cause chorea. Postpartum, you can get chorea apart from pregnancy, and it can be due to connective tissue disorders. Most important examples are SLE and APLA. I've seen a lot of APLA patients having chorea. So in exam, APLA causing chorea is also an important entity. And we have idiopathic chorea, which is also very common in clinical practice. As far as Sydenham's chorea is concerned, usually the questions will be more based on the Sydenham's chorea only in your exams. So that is because it's coming due to acute rheumatic fever. So one point that you need to note about Sydenham's chorea is it's going to have a higher latency, which means your carditis and other features. You'll be studying that Duckett-Jones criteria. In that, carditis will be there. Then you will be having erythema marginatum, so skin lesions, then arthritis. So all these things will come very early, as soon as the acute rheumatic fever comes. But this chorea is something that's going to have a little bit of more latency, by approximately 2 to 5 months classically. So which means it's taking a long time after the attack of acute rheumatic fever. So the latency is very high. If they ask you one acute rheumatic fever event that happens with a lot of latency, that is Sydenham's chorea. And at the same time, there are some classic clinical features that they'll be asking you that is associated with Sydenham's chorea, or any chorea for that matters. Chorea will typically have hypotonia. You can understand, like, only if you have hypotonia, you will get that movements. If you have hypertonia, you cannot get more movements. Rigidity means with a loose limb only you can get this kind of movement. So hypotonia is a very common association with chorea. And then only you can easily move the limbs. That hyperkinetic movements can happen. So you can imagine that way. That's a very important point actually in exam. Hypotonia is one of the important causes, chorea. And they can get something called spooning of hands, very classically. Whenever you ask the patient to outstretch, keep the hands outstretched like this. I cannot show here. They'll automatically go for spooning like this. So that's a kind of a spooning that you get. Then you can get something called a milkmaid grip or a milkmaid sign. When you ask the patient to hold something, maybe your finger, they'll have an alternative contraction relaxation like this. They'll not have a consistent grip on it. So this is what we refer to as kind of a milkmaid kind of a grip. So where you milk a cow, that's called a milkmaid kind of a grip. That is due to intervening hypotonia, which means they cannot consistently maintain the grip because they have intervening hypotonia. So that during hypotonia, they leave the grip. So that's the reason why you develop that milkmaid grip. Then you have something called a pronator sign. Remember, this pronator sign is different from what is called a pronator drift that you get in human lesions. In human lesions, there is something called a pronator drift where you ask the patient to outstretch the hands and put the hands like this. Once you put the hands like this, automatically the hand that is affected with human lesion will go like this. They will go down like this. They will pronate automatically and they will go down also. So this is what we refer to as a pronator drift that happens in the setting of a human lesion. So usually pronator drift is not used for patients who are having like obvious human lesion, like severe weakness. It is used for occult human lesions. When the weakness is not that obvious, you'll have a decent power, but you still feel that it's not like the other limb. So in that setting, pronator drift may be very useful. Pronator drift is different from pronator sign. Pronator sign is like, you'll be using the same thing, like when the patient is outstretching the hands, automatically, like they'll not keep the hands like this, they will pronate usually. Or if you ask the patient to keep like this, they will do like this. This is the pronator sign that you get in the setting of chorea. Pronator drift is different. That happens in occult human lesions. Pronator sign is happening in chorea. At the same time, they can get something called a jack-in-the-box tongue. That's a fly-catching movement of the tongue. That's called jack-in-the-box tongue. And most common complaint whenever Sydenham's chorea comes, because young children will be affected with Sydenham's chorea, and very commonly they'll be complained to have that some sort of a fidgetiness. Fidgetiness means restlessness. They will be keeping on moving here and there. They'll be doing something. So that's how the mothers will complain. That fidgetiness is the usual clue in exams to find out a Sydenham's chorea. And of course, other points are also important. So if they ask you the treatment of Sydenham's chorea, so how will you treat this Sydenham's chorea in general? The first one is, of course, the first line treatment is haloperidol that reduces the movement, number one. And second is, second line options like other drugs, like clonidine has been proven to be effective. And you can use valproate also, which alters the mood. It's like a mood stabilizer. So you can use valproate also in this setting. Suppose if it's a refractory Sydenham's chorea, then in this setting you can use intravenous immunoglobulin. IVIG is also advocated because it's an antibody-related disease. You know, rheumatic fever is due to molecular mimicry, and the damage is done by the antibodies that are mistaking it to be a group A streptococcus antigen and damaging the body's own structure. So the mechanism is molecular mimicry. So that's the reason to counteract that antibodies, you can use something called IVIG, which may be effective in the setting of refractory or severe Sydenham's chorea for that matters. I think this must be it, and this must be useful. And remember, many of the Sydenham's chorea patients may also have this kind of, one more point I want to tell. Yeah, OCD, obsessive compulsive disorder. They can have obsessive compulsive disorders, Sydenham's chorea. And second part of chorea that you need to know is Huntington's chorea, which I have not discussed. Huntington's chorea. Basically, Huntington's chorea is an autosomal dominant disorder. And the Huntington gene is basically present in chromosome number 4. That's where the Huntington's gene is present. And typically, it's a trinucleotide repeat disorder. And it's a CAG repeat disorder, which means it's a polyglutamine disorder. We have discussed already. One of the classic examples of a CAG repeat disorder is Huntington's disease. So how many repeats? If it's beyond that, it's going to have a severe disease. Whenever the repeats are more than 40, you're going to encounter a severe disease. And of course, because it's trinucleotide repeat disorder, it's going to follow all the other patterns like genetic anticipation, and all this stuff. So which I have discussed already. More than 40 means severe disease. That's all. The reason is glutamine accumulation in the basal ganglia. Because of glutamine accumulation, there will be destruction of the GABAergic neurons, because glutamine is something very dangerous to any area. So that's why the CH repeats is going to cause more glutamine production within the cell. More glutamine production within the cell, they're going to result in neuronal degeneration. Glutamine is not very good, because glutamine is supposed to be osmotic in nature. Because glutamine is osmotic, they pull water into the cell and they destroy that particular area. That's why accumulation of glutamine is bad. That's why whenever there is a CH repeat, you have more glutamine is bad. They destroy the neuron. It's a degenerative disorder. So they're going to result in neurodegeneration. So for example, you can assume that because basal ganglia contains predominantly GABAergic neurons, that GABAergic neurons will be destroyed and they will produce reduced GABA. Because of reduced GABA, you're going to result in hyperkinetic movement disorder. Hyperkinetic disorder. That is chorea, classically. That's why the name came Huntington's chorea. If you want to know the triad of Huntington's chorea, the first one, of course, is the movement problems. That is chorea. Second one, they will have a lot of psychiatric disorders like psychosis and depression. And third is the dementia, the neurocognitive dysfunction that these patients have. And of course, this will have a strong family history because it's an autosomal dominant disorder. And the usual age of diagnosis is around 30s. That's where you diagnose. And average survival will be for 17 years. The mean survival is 17 years, and usual diagnosis is made by around 30-35 years of age. That's where you make the diagnosis. It can be in younger patients also, particularly in the setting of a genetic anticipation, but typically diagnosed in the 30s, 30-35. That's the time you diagnose very commonly Huntington's chorea. And treatment, of course, you're going to use haloperidol only, because this is a hyperkinetic movement disorder. Haloperidol may be effective in treating psychiatric problems. At the same time, it will be effective in treating the chorea also. Or you can use other drugs like tetrabenazine that reduce the dopamine so that you can reduce the abnormal movements. Plus or minus, if the patients are depressed, you have to use antidepressants as well. So it's very difficult disease to treat. It's a progressive neurodegenerative condition. Only like supportive treatment. All these things, what we are doing is only supportive treatment to reduce the movements and to make the psychosis and depression better. Apart from that, they don't have any definitive treatment. And most of the neurological diseases do not have any definite treatment for that matters. I think, of course, that completes the session and completes the neurology also. With this, I think, again, this is sort of a power pack session and where you learned a lot of stuff. I think with this, we can finish off neurology, and next chapter after lunch, we can start with probably rheumatology. Basically, I want to cover neurology and cardiology in a great depth and detail because, I mean, that's what every student feels it to be difficult. Hopefully, these sessions would have been useful because we have discussed, I think, around 30 plus hours in both neurology as well as cardiology. So that must cover as much as possible for your exams. I think with the neurology and cardiology, whatever I've covered till now, whether it may be a final year exam or whether it may be a practical exam or whether it may be a NEET PG exam, doesn't matter. Whatever may be the exam, you will be able to really answer at least 95% of the questions for sure, with a lot of confidence, I can tell. So don't worry about that. So now I can go for lunch and come back by 4:15. So I'll start the class. Thank you. Bye-bye.